Okay. So you have a quiz due on Friday by 11:59 p.m. So now we're on the Monday, Friday quiz schedule. So I'll probably try to remember to send out a reminder for this week for Friday, but I'm not going to do that every week. You guys are going to be on your own. But because we had a week off, I thought it might be wise to remind you of the responsibility you had today by noon. Okay? Those BB Learn announcements are important. There should be 3 that you got. One was reminding you of the quiz. One was letting you know that there are some error messages that are showing up. So I started getting a couple of emails from students saying that the quiz was having error messages. And then the last one was this information that just came today on the SI schedule. Okay? So there's an SI today from 3 to 4. There was one before class, and then you have another one tomorrow, and then one on Wednesday. And I know that SI attendance hasn't been top priority on your list because we really haven't had much class. But this week, I think it's time to get into the habit of going to SI at least once a week. Somebody's in my office hours this morning and asked, what should I be doing to be successful in this class? And going to an SI at least once a week is a critical step. Okay? If that's not enough, then I go twice a week. And if you're not coming to my office hours, you're not going to SI, that's probably the feedback you're going to get from Taryn and I on how to do better and how to understand the material better. Now, the pre-quiz is a little bit easier. It's intentional to be a little easier than the post-quiz. So Friday, the post-quiz might be a little bit more challenging to you. Some of you have already told me I didn't do as well as I wanted to on the pre-quiz. Well, that might be your freebie, okay, because you drop the lowest pre-quiz and you drop the lowest post-quiz. The odds you get your freebie right at the beginning of the semester, but at least you have one to use, okay? Some of you sent emails about some of the questions, and I didn't answer those because I wanted to respond. The number one question that I got was pathology, and it's actually this slide right here. So the study of suffering, and we defined it last week. It's the second slide on the deck for today. But there's also an answer that said bridges clinical practice and basic science. And so it was 2 of those answers. That was the most correct answer. A lot of you got the study of suffering, but maybe you stopped reading or you didn't read all the rest of the answers. You just said, oh, yep, that's the right answer. You clicked it and you went on. So you want to read the whole question. And the reason I didn't respond to some of you this morning is because the quiz was still live until noon. And so, not that I feel like you're going to go tell somebody, but if someone overhears you, complaining about me, oh, he said it was 2 of these, what a tricky question, he's such a lame teacher. And they're walking by the hallway, they might catch that information and know, and now they have an unfair advantage. Okay, so in policy, we try not to talk about the quizzes until after they close. Okay? So if you go to SI session, Taryn will walk through the entire quiz. She has access to the entire quiz and all the questions. Actually, you have answers. You have the answers now if you go back into your grade book because the quiz is closed if you took the quiz. Okay? But what she won't be able to do until after Friday at midnight, I don't know about her schedule, but I'll be asleep at that time. She won't be able to go over the post-quiz until maybe next week in SI session at 10 a.m. on Monday. Make sense? So just trying to give you a little bit of the mechanics. So if you didn't get a response to me on an email this morning about the quiz, that's the reason why. And there were a handful of them, so I just decided to tackle it. Okay? Before we get started on content, why did the dog cross the road twice? Right? Why did the dog cross the road twice?
Have his motives question.
What's that?
Have his motives question.
Have his motives question. That's a little bit more advanced, I think, than a 7-year-old would write, but that's a good answer. He was fetching a boomerang. Okay. How did the ice feel when it heard it was fired? How did the ice feel when it heard it was fired? Cold, wet. It was crushed. Okay. What did the femur say to the patella? I may or may not have helped with this one. What did the femur say to the patella? What's that? You're fat?
I find your joke quite humorous.
Ooh, that's pretty good. I find your joke quite humorous. I need you. But I like yours too. Very good. Good, clean fun, right? Any questions before we get started? So, really last week was a little bit of an anomaly. This week we're going to have more of a regular experience. And we're going to try our best to stay on pace. If I get behind in my lecture, okay, I don't rapid fire slides. I'll just stop, pick it up there next week. Okay? And then usually before the exam we kind of get caught up. If I fall behind because I get off topic on some story, we'll pick it up next week, and I can usually make up very comfortably a couple of slides here and there. But I won't just rapid fire through the slides. Okay? So don't worry about that. If you printed out your slides, which is great. Some of you wanted the PowerPoint, so you came to my office with a flash drive. That's an option too. If you'd rather have PowerPoints versus PDFs. Okay? But again, I think the best way to do this class is to look through the slides, the lecture, read the, I would do that first. Then I would read the assigned reading, okay? Because what's inevitably going to happen is you're going to be drawn to the stuff in the text that you saw once in the slide deck, okay? And then after you've read that reading, you might have all of that literature available to you at your fingertips, and then take a quiz, a free quiz, okay? Because it's open book, open notes. Then you come to the lecture, and we go over that slide deck again, and you might have jotted down a couple of questions. There might be a quiz question that you didn't understand why you missed, or you're just not sure what it was asking. We may or may not cover it in lecture, but you can cover it specifically in SI, okay? And then you do a little bit more studying midweek. I would review that slide deck and your notes that you've taken on the lecture slides, and then I would gear up for the post-quiz. And in the post-quiz, you're probably going to do some Google searching. Okay, you're probably going to be either on PubMed, right, or I know Wikipedia is an option. Just be careful on Wikipedia on what you read, okay, because pretty much anybody can post anything there. I prefer Google Scholar, okay, which is the modern-day version of PubMed. Not just Google, but go to Google Scholar, and it'll search peer-reviewed papers. You can pull up abstracts. A lot of times you can look for keywords, maybe in the question, that pulls up the medical literature that's peer-reviewed. There's nothing wrong with any of this information. When you get into the professional world, you will have all of that in your fingertips, right? Well, actually in your back pocket, okay? And so it's not a problem to search for it. That's part of the skill set this class is sifting through good information versus bad information. If you're a future physician, the only thing that you use as a reference is Wikipedia, you're going to get in trouble. Okay, so you're going to need to know, how do I search other websites and how do I look for good information? Okay, if it's a cancer question and it's a cancer foundation, that's probably good information. If it's a diabetes question and it's the American Diabetes Association, that's probably a good resource. Okay, but if it's Wikipedia, it may pull from those resources, but you need to be a little bit conscientious about where you're getting info. Make sense? Okay. So that's kind of the plan, the landscape. I heard some comments like, I thought this class would be harder than it is. Seems to be, hold on, okay, last week was an anomaly, so we're going to get a large volume of information this week, and it's going to start, right now. But if you've done the pre-work, I won't hear as often from students, it feels like you're going so fast. Like that's the number one feedback I get is, man, you need to slow down, you're going so fast. If it's the first time you're hearing this information, it's going to seem really fast. Okay, but by now, the definition of pathology, right, and all of the things that are associated with pathology should be pretty clear to you. It's been like 2 weeks, 3 weeks that we've been resting on this particular topic. Okay? And the big theme for today that we're going to go through is we're going to talk about what happens at the cellular level. So we're really going to go into the cellular mechanics of what happens to the cell in a disease state, okay? And then we'll blow back out to kind of the tissue level, and we'll look at examples when a collection of cells have problems, known as a tissue. And we'll see not just microscopically at the level or subcellularly at the level of the cell, but we'll also look at the tissue response. Okay, and we'll look even at the gross tissue response. We'll see some, if you've looked at the slides, we'll see some pictures of organs that have damage or necrosis. Okay? And then we're going to categorize certain things. And at the very end of the lecture, we're going to go back deep into mechanism. And you probably saw some scary looking mechanistic slides at the end of the lecture that talked about all these different pathways and things were going up and things were going down. And routinely, those are the slides that students struggle with the most. Okay, I'm just painting for you the story that we're on today, okay, for the next hour 45. Okay? So, knowing what that outline is, and if you've already looked at those slides, you kind of know which ones I'm talking about. Right in the middle, there's some yucky looking slides, and at the end, there's some scary ones with all these arrows going up and down. So that's where we're headed. Okay? And of course, we finish it out with some yucky looking slides again. Okay? Like an aortic valve stenosis and all sorts of different things. Questions before we get started on today? That's kind of the storyboard. So first up is a nice little flow diagram. This is a great summary slide because it gives you an overview of what we're going to talk about throughout today. You can kind of see at the top we've got a normal cell in homeostasis. Who can define homeostasis for me? Anybody?
A constant state of equilibrium.
Okay. Constant state of equilibrium. I would prefer the word maybe a steady state instead of constant. A steady state of equilibrium, but I think you could argue that's an accurate definition. Equilibrium being the key. Things that fluctuate around a normal set point. You've seen this in a lot of your bio classes, okay? But because we mentioned it in lecture, is it fair game for me to ask a question about homeostasis on the exam? And that's kind of why I did that. Can I fairly ask you to define homeostasis on the exam? Yes, I can. Could I then actually ask you an example of a homeostatic mechanism that we talked about in today's lecture? Yeah, that would be totally fair game. You with me? So that's how the class is going to work. Well, all throughout the day, your and my cells experience stress. And when that stress shows up, we adapt. Hey, a great example is, a visible example, is if you go sunbathe, right, you're getting UV radiation. As you walk around campus, you get UV radiation. Now we're in that season where it's still warm, it's still nice, so we're still in our flippies, right? And so if you're like me, you notice, when you take off your flippies, you've got a nice little Flagstaff flip-flop tan. Okay, that'll fade as we move into winter, but that's evidence of an adaptation. And that adaptation is to UV radiation. And so that UV radiation is penetrating into your skin, and your skin is responding to that, and it does it by upregulating the amount of melanin that it produces, that dark pigmentation of your skin. Some of you would say, that doesn't happen to me, it just goes red. Okay, so your adaptation is not as protective as other genetic gene pools. If you don't tan, for example, and you just burn. Okay, so yes, you might be more predisposed to sunburn and even cancerous lesions of the skin than maybe other populations that have a better tanning mechanism or more protection with respect to melanin content in the skin. But for all intents and purposes, this adaptation works actually pretty well. Okay? If it is a stimulus that causes damage to the cell and there's an inability to adapt, then we push this over to the right side of the slide, and this is when we get a lot of problems, cascade of problems. Okay? Now, we see adaptations not just with the skin. We see adaptations with the liver. Okay, the liver detoxifies our blood. There's all sorts of things in our environment, including the medicines that we take, that interfere with normal hepatocyte function. Okay, and they're toxic. We're going to see an example later today of acetaminophen. Does anybody know what acetaminophen is? Tylenol. Okay, bless you. Tylenol. So Tylenol is the brand name. Acetaminophen is the drug name. And it's actually a hepatotoxin. It's toxic to the liver. And the liver detoxifies all drugs, including acetaminophen. And we'll talk more specifically about that pathway later on today. But for the most part, the liver will adapt as it is seeing toxins and detoxifying the body. It's eliminating them. And then there's a reparative process that happens, and it kind of fixes itself. Now, if in the case of the liver, let's say, for example, alcohol. Alcohol is a toxin as well. And the liver, we won't talk about it today. We're going to talk about it in our liver section later in the semester, but I'll allude to it. If alcohol, which also is a hepatotoxin, causes damage to the liver, but let's say it's chronic over a long period of time, and now the liver is going through permanent damage, okay? Then we move into these classifications of, we might have something that's reversible cell injury, and we see that in liver toxicity. We see in early stages of liver toxicity that it is reversible. The liver can repair itself. But if the insult was to continue, we might see this necrotic response that takes place at the level of the liver, and we move past this point of reversibility, and you have permanent damage, or we have scarring of the liver, otherwise known as a cirrhotic liver. Okay? So these are all probably buzzwords that you've heard, and what we're doing is just using an example to take us through what happens in a necrotic response. Well, there's another side of this graph, and that involves other types of subcellular changes or alterations. And so we're going to compare and contrast apoptosis with necrosis throughout today's lecture. Apoptosis is really a programmed cell death. It's like an organized cellular suicide. And have mixed feelings about using that language, but you'll see that pop up in the literature. Cell suicide. It actually is a real terminology that's not just found, in the public domain. It's found in peer-reviewed publications. So, programmed cell death, and let me give you a couple of examples. Okay, everybody put your hand down. Okay, what do you notice about the digits? Is there any tissue in between? Okay, very little, all the way at the base, right? Some of you, maybe it's a little bit higher than others, right? Some of you probably know, folks, it's more common on the feet, but there's a lot of tissue, they have webbing, right? Well, all of us at one point in utero had webbing, and through an apoptotic signal, the digits delineate. And so we turn these cells on for apoptosis, and now you have the webbing disappear during embryonic development, and you actually have specific digits. Okay? So apoptosis is programmed, meaning it's meant to do that. It's supposed to do that. We'll talk about a couple of other examples as the lecture goes on, but I just want to give you an example of apoptosis being almost a healthy way to get rid of a cell. Necrosis, on the other hand, is very different. How many of you have actually had an infected wound? Okay? How many have actually treated a patient that had necrotic tissue? What did you notice about it? About that necrotic tissue in that patient, or in your own wound? It was dark. The skin gave, the structure was compromised, the skin gave way.
You could be missing like chunks of skin.
You could be missing large volumes of tissue. In some cases it smells, right? Necrotic tissue is dying tissue and it smells. It is not well organized necrosis, okay? It is just almost global tissue damage, okay? So those are the two big differences between the two. All right. Let's talk a little bit about cellular adaptation. So we adapt to toxins. We adapt to stresses. We adapt to like UV radiation. Well, these things that see our cells on a regular basis cause these cellular adaptations. But there's also signals that are physiologic signals that trigger cellular adaptation. And those would be considered normal. Okay? Homeostatic physiologic examples. So physiologic cellular adaptations would be anything that is a result of normal development or embryonic development, like apoptosis and interdigitating the hands and the feet. Pathogenic alterations usually is a result of a disease that's perturbing the system, okay? Like inflammation, severe chronic upregulated inflammation in the tissue. Another adaptation of the cell is atrophy. That's a loss of cell size. Another cellular adaptation could be hypertrophy, where it gets bigger. Hyperplasia, where we see an increase in cell number. Or metaplasia, like we talked about 2 weeks ago with our example of Barrett's esophagus, where we get the conversion from one differentiated cell type into another. All of these are examples of some adaptations that can happen at the cellular level. Further on that point, we talk about cellular adaptation. This is an example that comes really from the last part of the semester, the end of the semester, when we look at cardiovascular adaptations. So in the middle, we start in the middle. This is a slice that's a coronal slice through the heart. So on your right side, or the patient's left, is the left ventricle, and your left side, or the patient's right side, is the right ventricle, and this tissue in between is the septal wall. And if we look at an example in cartoon format of myocytes that make up the myocardium, they can go through different adaptations. So if you increase the load that the heart sees, the load that the heart has to work against, like blood pressure goes up, okay, in patients. If we increase the load, you go on the left side of the heart, this stimulates the cell to enlarge, becomes hypertrophic. Skeletal muscle behaves very similar to cardiac muscle. So I see some individuals in here that look like they do this on a fairly regular basis, right? You go into the gym, you load skeletal muscle, it responds by getting larger, okay? That's a hypertrophic response. And that's exactly what happens at the heart. And you can see at the gross level that this septal wall and this myocardial wall are much thicker than they are normally in a hypertrophic heart. So if the load that they see isn't a dumbbell, but the load that they see is increased mean arterial pressure, the heart responds by hypertrophy. Okay, on the right side, or the right diagram, we look at cellular injury that's different than loading the heart. This is in response to losing blood flow. So if you decrease blood flow to the myocardium, usually because one of the feeding vessels is narrowed or has atherosclerotic disease and perfusion to the functioning myocardium is decreased, then you have ischemic injury. Okay? And when you have ischemic injury, you see reorganization of the myocyte, and eventually you get cellular death of the myocyte in the form of necrosis, not apoptosis. And when you have cellular injury in the form of necrosis, this region of the heart right here, that's kind of this yellowish white color, there's a little bit of dark coloring right here. This is truly necrotic, and this is fibrotic scar now that's yellow. But this kind of wedge shape, you see this sort of wedge shape? That's the infarct, the myocardial infarct, or the heart attack. And that is non-reversible. This, to some level, is reversible. If you unload the heart, a lot of times it'll come back into its normal size. Okay? Just like if you stop working out with the dumbbells, you'll kind of see reversibility of that hypertrophic state of skeletal muscle. Questions?
Is there any situation where apoptosis would occur from injury, or is it that only necrosis?
Now, so the question is there any examples of when apoptosis might happen as a result of injury? It can. So apoptotic signals can be stimulated. If it's almost like an organized evacuation. So if the cell realizes that this is going to go bad, it might try to organize around apoptosis. But in the case of an infarct, when you lose blood flow, you don't have the tissue doesn't have time to respond. So it just goes through this sort of necrotic all-ditch effort. Right?
I believe there's two main types of heart attacks, with myocardial and ischemia. But what's the difference between the two?
So there's ischemic myocardium that you have slow reduction of blood flow over time, and so the blood perfusion to the myocardium is decreased over years. And then there's what's called an infarct, where there's a sudden occlusion, and then the blood flow is ceased like instantaneously. So usually it's kind of a combination of both. Usually the vessels narrow over a 30-year period of eating Lay's potato chips. Sorry to throw Lay's under the bus, but any brand of potato chip, okay, it'll start narrowing. And then if you have a lesion that comes in, like an embolism somewhere else that comes through, or some fragment of the lesion that breaks off, it'll go in and it'll plug the smaller reduced hole. So usually it's sort of a combination of the two. So where you see this show up is, like dad or grandpa. Why am I picking on the men? Because it's mostly men, not always, but it's mostly men. So dad or grandpa will go in their 50s and 60s, and they'll get a scan of their heart, and they'll say, hey, like 3 of the vessels are like 60% narrow, and one of them is like 80% narrow. And dad or grandpa will say, yeah, I've had more trouble kind of going up and down the stairs. I get short of breath when I do that. That's what stimulated them to take a picture or an angiogram of the heart. And they're saying, hey, you're probably under-perfusing the heart when you exercise with that 80% occlusion. We're going to come in and open it up with a stent, and we're just going to watch the other 3 vessels because they're only 50% occluded. Okay. So that's how that. And that 80% occlusion, if you're exercising, it becomes a problem. If you're at rest, it's probably non-symptomatic. So, but the risk factor is, because it's 80% occluded, if an embolism was to break off and lodge, it would completely block it, and then dad and grandpa would have a heart attack. And so that's why they go in prophylactically and put a stent in.
So that many years of it being included, can it be reduced with exercise and healthy eating, or at that point it's just like too far gone?
No, so the bummer for us as creatures is that atherosclerotic disease is non-reversible. So you go in and you have to mechanically remove it, like roto-rooter it with a catheter technology or crossing catheter technology, or you'll balloon it, push the plaque lesion out of the way, you'll put a stent in. We used to open the chest and bypass it, bypass surgery. We don't do that as much anymore. So these are all great questions for the last segment of the semester, which is, but I don't want to be like blow you off for like 14 weeks. No. Yes, sir.
When it comes to hypocrisy, so you said as we work out, for example, like the heart would slow up the cells. Is that correct?
So with exercise under normal physiologic homeostatic norms, the myocardium of the heart isn't going to change hypertrophically all that much. Okay, because it goes up and it goes down. It might slightly enlarge with exercise, but you have a lot of elite athletes that have cardiac hypertrophy, and they have a genetic abnormality for that.
So is it like, does that count as beneficial as the heart pumping more blood and cause damage to the lung?
Well, it's beneficial in the short term, but it's a compensatory mechanism. And it's one of the early signs of cardiac failure. And so we see parallels between patients that exercise chronically, especially in that population like in the 70s and 80s that were using a lot of androgenic steroids. We see a lot of clinical examples of severe cardiac hypertrophy. All the way to the point where some of those patients had the chest open and they had a wedge of the heart cut out and removed, and the heart actually physically shrunk in size. And the Governator had that procedure done, although it's not highly publicized. Arnold Schwarzenegger actually had a heart reduction surgery many years ago.
So,
Okay. Last question here, and then we gotta move on. Okay. Gotta move on. I know this is like, I should have brought weights into the front of the room and asked somebody to demonstrate. Some monster biceps everywhere. Okay.
so that was
What's that?
the autopsy essentially.
Yeah.
So
Yeah. I know. I'm thinking about that as I'm talking. Okay. So let's talk about the opposite. This is going to be less interesting, I think, to this room, right? We're not getting larger. Everyone wants to get larger, right? But we can talk more at the break if you have other questions, or we can talk offline too. Okay. So atrophy also happens. Cellular adaptations of atrophy. So this is an interesting case. All right. This is obviously postmortem. This is at autopsy, and there was a loss of blood flow. So on the left is a normal brain of a young adult, okay, about the age of all of you. Yes, we do have autopsies on young, healthy individuals. It does happen, unfortunately. Okay. So on the left, this is a normal, healthy young adult. And you can see on the right hemisphere, the meninges are still intact. That's why it looks kind of gnarly, right? That's just the meningeal layer. So if you think back to 201, when you dissected those sheep brains, some of them might have still had the meningeal layer and others didn't. So this side, the meningeal layer has been removed on the left side of the patient. Excuse me. So you can appreciate the shape and the relative size of the gyri and the sulci. And then on the right side of the screen is a relatively healthy 82-year-old male that had evidence of global atherosclerotic disease, including the carotids that perfuse the brain. Okay, but didn't die of stroke. Died of some other unrelated incident. 82 years old. Lots of things go wrong. And similar prep, and they were about the same weight, about the same size. But what I want you to appreciate, what are some of the things that you notice? Young brain, old brain. Okay? What are some of the things that you notice between the two different brains? Just grossly, observationally.
The sulci, is it? Like the dips in there are deeper?
The sulci are much deeper. Okay, those are the invaginations, right? What about the gyri? Do they look as plump, so to speak? Or as full? As enlarged? No, so we have atrophy. Why do you think we have atrophy of an older brain? If I told you there's underlying atherosclerotic disease, and let's say the carotids were like 70% narrowed, but no stroke, are they at risk of stroke? Yeah, just like any other 82-year-old. Okay? But knowing that there's global atherosclerosis and the patient's 82 years old, what can you assume about the condition of the brain? It's not getting as much blood flow. Right? Over 82 years, the blood flow has lessened. And so now the tissue isn't nearly as perfused as it was in a younger patient. And so the cells respond. They shrink in size. They're not getting enough nutrition. They're not getting as much nutrition. So there's no stroke. It's just long-term, slowed down blood flow. Okay? Atrophy. The opposite, hypertrophy. An example that's away from the heart. Okay? So this is actually the uterus. And this is an increase in cell size that's not considered pathologic, like what we saw with the heart. This is an increase in cell size that happens physiologically, normal physiology, of a gravid uterus on the left, and then this is just a pregnant uterus, and then a normal-sized uterus just to its right. Similarly, if we look at the smooth muscle cells that are primarily what's found in that uterine muscle, in the middle panel, the very middle panel, we see a quote-unquote normal or a non-pregnant uterus. And these cells, I will use this, are spindle-shaped smooth muscle cells. So spindle shape means that they look like this, right? So this is a smooth muscle cell. This is the nucleus, and they look like a spindle. So they're kind of fatter in the middle, and then they kind of narrow at the edges. And then if you look at the far right, the morphology of these cells are like this. They're swollen. They're hypertrophic. And that's a gravid or a pregnant uterus on the far right. Okay? Normal physiology. Right? This is what's supposed to happen. This isn't pathologic. Okay, also normal physiology example. Hyperplasia. Now, when we move into the cancer lecture, we talk about hyperplasia. That's pathogenic. But when we're talking about pregnancy, the uterine lining, or the endometrium here, is actually going through cellular proliferation. Okay? And that's what you're looking at on this inner lining. We're seeing endometrial glands. These are these big bulges. And we see this darker pigmented tissue compared to the lighter pigment. This is where there's a higher density of new cells in that endometrial lining. That's why the pigmentation is darker, because there's more cells present, and so the light is actually having to penetrate through a thicker layer of tissue. Then we move to pathogenic example that's different than Barrett, but Barrett's an example you could write on your slide. It's very similar to Barrett. Now, let's remind ourselves what happened in Barrett esophagus. We had a normal stratified squamous becoming what? Someone said it over here. Simple columnar, I heard you. Simple columnar with goblet-containing cells. Okay? That was the metaplasia. That's pathogenic. That's not normal. Here we see another example. This is called smoker's metaplasia. And what we're looking at in the cartoon on the top is we've got normal ciliated columnar epithelium that line the airways. And over a long period of time of injury, because there's contaminants in the air or particles in the air, we see a change. We see metaplasia to a squamous epithelium, which should make sense, right? Because now the airways are saying, well, if the air that's coming in is particulated and is going to cause trauma to the epithelial lining, then I should move away from ciliated columnar epithelium and I should move to a stratified epithelium. Stratified epithelium is what you see on the skin for abrasion, in the mouth, lines the trachea, okay? That's for abrasion. And so this is another example, and here's the histological corollary. So here you kind of see the columnar, ciliated columnar epithelium, and this is that transition zone, and now you've got stratified squamous epithelium. I want to give you a couple of examples. This comes from the University of Iowa, from their medical school. This is pathology from a patient. You can see species human, organ, lung, diagnosis, emphysema. This patient passed from complications associated with lung cancer. And we're going to zoom in. We're zooming in here. Zooming in a little bit more, you can see that the green arrow is pointing to the histology of columnar epithelium. And the red arrow is showing where it has gone through a transition. It's metaplastic into stratified squamous epithelium. Okay? Questions? Yes?
Is there a physiologic example of metaplasia, or is it always pathologic?
That's a great question. I can't think of a physiologic example of metaplasia that I can share with you. I can research it a little bit, and if I find one, I'll post it for you. Okay, that's a great question. I doubt it, because it's not supposed to change once it's been developed. I mean, the way it's designed is for you to replace the tissue that's there, not necessarily go through an alteration into something else. Yes?
Can you explain hyperplasia again?
Hyperplasia just means an increase in cell number. So the cells divide and they create, instead of 2 cells, now 4, instead of 4 cells, now 8.
So they just increase in number, not in size.
Increase in number, not in size. Yep. Hypertrophy specifically refers to an increase in the cell size, but not necessarily an increase in cell number. Okay.
Would the calcification of cartilage count as metaplasia?
Calcification of cartilage. Wow, that's a good example. That would be the closest thing. Yeah, I mean, you could say, so cartilaginous tissue becoming bone. So it happens into your adolescence, and then it stops. So you have to think of something in an adult state. You know, once the growth plates close, then you no longer get ossification of cartilage. But that would be the best, closest example. That's a really good one to share. So like the growth plate, right? So we have this turnover and you get cartilage, and then as the growth plates enlarge, the cartilage ossifies and creates new bones for the long bone. But you know, about the age of 18 for men and women, plus or minus a couple of years, a lot of that cartilage ossification ceases because those growth plates close. So that would be a great example. Okay. So now we're going to move into, thank you, sir. Now we're going to move into cellular injury and cellular death, and we're going to be looking at some of the causes of injury. Okay, so there's a long list here. This isn't an exhaustive list. It's just an example, okay? It's to try to cover as many of the different possibilities that we might experience throughout the semester. So one thing that I want to point your attention to is the one at the very bottom of the list. Age. Bless you. So age is considered a pathology. So when you look at geriatric patients versus pediatric patients, old patients versus young patients, they're two completely different fields of medicine, right? Perfect example. What might be an example of healthy, normal metaplasia in an adolescent or a pediatric population with ossification of the cartilage doesn't exist in a geriatric population, okay? In fact, you lose ossified tissues in a geriatric population with osteoporosis, okay? So age is considered a pathology. So whenever you're reading the literature and you're looking at a study design, one of the first things I look at is the age of the patient population. And was there this wide range of age? And it's very common to read clinical trials where patients were enrolled between the ages of 40 and like 82. Why? Because that's what they got, right? If they had a patient that they were studying for neurovascular aneurysms and they presented at the age of 45, they didn't want to miss out on that data point, so they enrolled the patient, okay? But a 45-year-old has a very different type of physiology than an 80-year-old, okay? So age is a pathology. Now let's go back to the top. Hypoxia. Hypoxia can stimulate cell injury. Hypoxia will do this through many different types of forms. And we're going to study that throughout the semester, where we've got low oxygenation in the tissues, and disease states will ensue. We can have hyperoxia, or too much oxygen, in the form of reactive oxygen species, okay? ROSs, free radicals. So in like the nutritional community, we like to eat a lot of foods that are rich in antioxidants, right? They're free radical scavengers. And that's for the reason of bullet point number 2, is to scavenge up those free radicals so they don't go around the body and react to something. All sorts of different chemicals, infectious agents, immunological reactions, we'll cover that in our immune section. Obviously genetic defects, we'll talk a little bit about those. Nutritional imbalances, okay, if a patient's low in magnesium or their sodium levels are off. And then of course physical agents, okay? So all of these things are causes of cellular injury. Some are more obvious than others. The one that usually gets missed is age, and that's why I kind of brought special attention to it. So this slide is here to start a discussion on reversible versus irreversible injury of cells. And all cells in the body have the ability to adapt to a certain extent, some more than others. But you can see at the top is a normal cell, and this green zone here is where the cell might go through different types of alterations, but it's still reversible. If the injury goes away, it can actually recover and output back to a normal type of cell. But then you get past this point of reversibility, which is kind of this border between the green and like the pink color on the slide. And down here is where it's irreversible. And we go through some intracellular alterations, subcellular alterations. Ultimately, it'll persist all the way to the point of cellular membrane and nucleus fragmentation. And this is the signs of a necrotic cell, usually found in a necrotic tissue. Earlier in this process, before it gets here, when we look at some of these alterations that take place in the reversible sign, is we might look at the cell starting to swell or enlarge. We might look at fatty content starting to change. We may actually see certain intracellular markers go up, like for example, P53. So P53, go ahead and write that one down. We'll come back to it in our cancer section. But P53 is considered a central monitor of stress in the cell. It's kind of like, it's referred to as the guardian of the genome. Okay, that's its like registered trademark. So if you're going to use Guardian of the Genome, like on a movie trailer, I think it'd be a great trailer. You're going to have to give credit back to P53. So P53 is upregulated anytime there's stress in the cell, and its function is to pause the cell before it replicates to check the integrity of the DNA, to make sure there aren't any mutations. If there's, a cytosine instead of a guanine, right, then it'll pause and allow that switch to take place so that it replicates accurately. That's one of the roles of P53. So all of this would happen in this reversible cell injury state. Now, when you get to the point of irreversible, you can either trigger necrosis or apoptosis. And we're going to talk a little bit more about both of those as we keep going. Okay?
Are all examples of checks for proliferation through 53?
No. There are many different.
It's just that's the main one that like deals with.
It's the one that's got the most press.
Sure.
So it pauses and checks for what?
DNA integrity. So it looks to see if there's any errors in the DNA. Like if there's a nucleotide that's been switched, it'll stop, allow for the correct nucleotide to go in and to replicate the correct nucleotide. Okay, so let's look at some examples of cellular swelling. So these pictures are kidney tubules. So we're looking at kidney tubules on the lower left. So these are simple cuboidal epithelium. And the middle picture is a picture of a reversible ischemic injury. So when the kidneys have a reduction of blood flow, and this could happen oftentimes like during stroke, or during shock, septic shock. So when a patient is losing large blood volume from trauma, the kidneys actually take like 30 to 40% of the blood flow right off the descending aorta. And so they have a huge appetite for large volumes of blood flow. They filter the blood as well. The liver obviously gets its blood on the backside. It gets its blood from the venous circulation. But the kidneys are kind of one of the main, after the heart gets its blood and the brain gets it, the kidneys are the next organ to get a large volume of blood flow. Okay, this is back to 202. So if during shock, blood volume is compromised, blood flow to the kidneys is compromised, you might see kidney tubule anatomy looking like this middle picture, where you're starting to see breakdown of the cell membrane. You're seeing some surface blebbing, right, where there's a word that talks about kind of pouches of the membrane kind of coming out, like right here. And you're even starting to see some of the nuclei being compromised. But you reestablish blood flow, and this will reverse. However, if you progress to the right side picture, the lower right side picture, this is irreversible necrosis, where you've got fragmented cells. You can see that they don't look like squares anymore. Okay, they don't look like the far left picture. They don't look like simple cuboidal. And many of them are anuclear. So the nucleus is gone, it's expelled the nucleus, or it's lost the nucleus, it's fragmented the nucleus. You cannot appreciate, like for example, this cell right here has no nucleus, no nucleus, no nucleus, no nucleus, right? So on and so forth. There's a ton of anuclear cells. If it's lost its nucleus, it's not going to grow another one back. Okay? It is irreversible necrosis. All right, so what's going on here? Well, at first, we might get what we call hydrophic change, right? Hydrophic change is referring to swelling, where the cells themselves start taking on more fluid, and the oncotic pressure increases. And as the oncotic pressure inside the cell increases, that puts pressure on the cell membrane, the cell organelles, as well as the nucleus. And that's physical trauma. And that physical trauma inside, it's like when you go up in an airplane before your ears pop, right? And you equilibrate, that's painful pressure. Imagine that at the level of organelles inside the cell. So they start responding to that physical stress, and they start shutting down. That's the hydrophic change. You start getting vacuolar change, where you get fluid coming in and filling up the inside of the cell in these huge vacuoles. At the level of the organ, now again, this is all reversible as long as that goes away and you haven't compromised permanently the nucleus or those organelles. At the level of the organ itself might be a little bit more pale in color because now it's got a higher fluid content. The organ itself will go up in weight because of an infusion of water. It's water weight. Okay, so if you measure a kidney at autopsy and you take weights of the right and the left kidney, and you notice that they're like twice the weight that they're supposed to normally be for that same sized individual, it's usually a sign that there's a tremendous amount of turgor pressure, increase in water from water flooding into the cells and therefore the tissue post-mortem. And then at the level of the cells, we talked about these vacuoles, these huge open spaces that are now full of water. And that's what's housing a lot of this increased water content. Fatty change, okay? Most commonly, people have heard of fatty change as a disease state in a tissue or in cells that's associated with too much drinking, right? So alcohol is a hepatotoxin. One of the stages of steatosis or of disease of the liver is you get switching from normal hepatocyte architecture, which is the top histological slide, to liver tissue that has large vacuoles that are full of fat. And the liver itself helps to stimulate ATP production by the breakdown of fat, okay, through lipolysis. And so if the liver is not functioning correctly, instead of breaking down fat to create energy, it stores fat, and it stores fat in its own tissue. And so that's the reason that you get all of these open, like bubbles in the liver. Those are all full of fat, and that's fatty liver. Those are lipid-filled vacuoles. This is actually reversible, believe it or not. In most other tissues in the body, that would be past the point of no return, but the liver is pretty special. The next stage here is actually moving to scarring, and that's fibrotic liver, and that is non-reversible. Okay, and that's a cirrhotic liver disease. So this is kind of that middle ground of liver disease of fatty change. Okay, let's talk about apoptosis, and then I have a little bit of a homework assignment for you, but you're going to do it right here. You're just going to talk amongst yourselves, okay? But it's a great study tool, the next slide after this one. But this slide is to highlight apoptosis, or what we call programmed cell death. We talked about the digits. Apoptosis is a Greek term. It's a Greek term that means falling off. And so the way that I like to think about apoptosis is like scheduled move out. Okay, so there's two different types of people that move out at the end of the semester. Okay, and I'm sure if you have roommates, you might have experienced both types. There's one type that, you know, like the week or two before finals, starts kind of packing up the stuff that maybe they've never used. And they label their box, and it says kitchen. They have a box that says, you know, living room, bedroom, bathroom, and the respective contents go into those each of those boxes, right? How many of you, that's the way you move out? I just want to see it. Come on, let's be honest. Come on, be honest. Okay. The other type of move out is the 31st of the month. You have to be out by 5 p.m. Finals were over a week ago, but you've been relaxing, okay? And now you bring your Honda Civic up to the front door, and you open every opening that you would have, and your roommate has already taken their boxes out. So everything else in the apartment, technically by default, belongs to you. That makes your job much easier, right? And everything that can go into the little Civic will, and of course the most important things you tend to put on the front seat, and then everything else just gets piled in, and whatever can't fit that's not essential gets, you know, donated to the next tenants. How many of you, that's your move out strategy? Okay, there's a few. Cool. Well, here's the difference, is apoptosis is kind of like the first example. It's very organized, okay, it's very anal, it drives you crazy for those of you that were the second population, I get it. But just to paint a picture, apoptosis is like a scheduled move-out. And what slowly happens over time is the cell gets a little bit smaller because the cell packages organelles into these vesicles. And it shoots those vesicles out so a neighboring cell can phagocytose it and use that entire organelle. Okay? Or parts of that organelle. So apoptosis is programmed. Carl Voigt was the first to describe it in 1842. He was a German scientist. It later was re-described by an anatomist, Fleming, and it was many, many years later, after the 1800s, in like 1965, that it was resurrected as a term in electron microscopy, where with electron microscopy we have the ability to view the inside of the cell. We can see these compartments that are being formed. Voigt and Fleming just hypothesized that this might be what's happening, because I don't see like this complete disintegration of tissue. So at the level of the cell, it must be a more organized process. So they made the theory, hypothesis, and it wasn't until like almost 100 years later, in the 1960s with electron microscopy, that John Ross Kerr at the University of Queensland coined this Greek term apoptosis in the way that we describe it today. Okay? So on this graph, or on this slide rather, you can see that if this cell is going to go down an apoptotic process, you see that it has these little apoptotic bodies that get launched out. And slowly over time, the cell gets smaller. A neighboring cell might ingest those contents and say, hey, thanks a lot, I'll use that little Golgi apparatus for my inner workings. Over here, the cell with necrosis, it swells. It takes on water, right? It swells. As it swells, it causes pressure on the nucleus and all the organelles. All of their membranes fragment, the membrane of the cell fragments, and it just sort of fragments apart. It lyses. Okay? So this is the compare and contrast. So I want you guys to work together with your neighbors and just identify differences between apoptosis and necrosis on this list. And then I'm going to have one more task for you after you have a little time to talk amongst yourselves. Okay? Ready, set, go.
What do you do? Your old
decide which one of these SEM pictures is necrosis, and by extension, which one is apoptosis. And use the table, use the table to help justify your answer. Okay? Make sense? So explain not just O, A, or B, tell me why. Why do you think that is? What features or characteristics lead you to believe that that's the correct answer? Okay, let's hear some answers and some justifications. You guys talking about football or something? Okay.
I think you would be across because the looks of it looks like the organelles are moving out really quickly versus looking at age where the organelles are kind of like slowly coming out. Kind of like what you said earlier with people moving out of apartments.
Okay.
So, yeah.
So you think B is necrosis?
Yeah.
And A is apoptosis? Okay. Any other support or contradictions, and why?
We thought that A was necrotic because it was swelling, whereas B is kind of shrinking down and there's more permeability in the membrane there.
So B has more permeable of membrane?
Yep. And then A is more swollen, so we think A is necrotic.
Okay. Okay. So some of you think A is more swollen, so A might be necrosis?
Well, it would depend on what the stage of necrosis, because technically A could be the beginning of necrosis, and B could be the end of it.
Yeah, so it depends on what phase of the process you're capturing. Okay, so that might be some of the discrepancies or the disparities. Okay, anything else? Yeah, there's a lot. Hang on one second. Let's go back here and get some new people. Right here.
So we thought it would be necrosis because of the loss of membrane integrity.
Okay.
Whereas A looks, it's all more attached together.
Okay. Okay. So I really like that answer. Not that I didn't like a lot of the other ones, but if you look at that membrane on B, it has giant. I mean, it's like shot up, right? It's got fold all the way through it. So you have a loss of membrane integrity on B. Someone said that A looks like it might be swollen. They're both taken at a 5,000x magnification. So if you put a ruler across those cells, they're not significantly different in size. Okay? A does have an appearance of something coming out right at you. You guys see that? And so it might have a look of being swollen. I get that. But that is a very specific structure that's coming out of you. What is that structure? That's an apoptotic body before it actually completely buds off. Okay? So yes, it does depend on where we're talking about. One could think and conclude that A looks swollen. However, if you put a micrometer across those, you would see they're about the same size. And what was mentioned here about membrane integrity on B, it looks mothy. It looks like somebody shot it with a shotgun. Okay? It's got all these holes in it. And you don't see that with apoptosis. Apoptosis, you typically see continuous membrane integrity throughout the entire process. And as one apoptotic body buds off, it just sort of pinches off behind it, and it seals up that membrane, nice and clean. Okay? So I wanted there to be a discussion because I wanted to see where you guys would trip up on a picture like this, and then use it as maybe a tool to kind of help explain what are some of the key features that we're looking at to be able to discriminate between the two different processes. Okay? All right, we're going to take a break here in a second, right after this slide. Let you guys have a bio break. So this is an example of kidney coagulant necrosis at the level of the renal tubules. And if we get down to the tissue level and we start looking at architecture, we see that there's a lot of degradation that takes place in necrosis. And one characteristic sign is that these cells lose their intracellular organelle function. And it happens very quickly. And so you can see throughout this entire slide, this is a chemotoxin and eosin stain. Chemotoxin stains extracellular matrix pink. Eosin stains pink, and chemotoxin stains the nucleus like a dark blue. And you would anticipate there to be dark blue nuclear structures lining each one of these circles, right? Inside these little circles, you would see all these nuclei, and we don't have that at all. So, for example, if we go back to this picture, we see these nuclei in here, and here we're starting to lose them. If we go forward to here, this is a further away magnification, but you can appreciate there are no dark purple circles inside any of those renal tubules. Okay, so this is what the tissue would be looking like as we move away from the cellular level. We start looking at the architecture of the tissue. We're seeing nuclear degeneration. This is irreversible. We see loss of cellular membrane integrity, and the cell itself is lysing, right, falling apart. Let's take a break, and then we're going to move it at sort of the organ level, and we're going to start characterizing different types of necrosis, okay?